Yeah.
All right, we're going to give it just a couple minutes for everyone on Zoom to trickle in. We'll get started. Very nice to see everyone. Thank you so much for being here today. It's very, very exciting. We are very, very honored to have the Special Rapporteur on the Right to Health with us today. We're celebrating the launch of her report. I hope a lot of you got a chance to look at it. It's Sexual and Reproductive Health Rights, Challenges and Opportunities During the COVID-19 Pandemic. I'll let Oscar introduce the Special Rapporteur in a second, but a couple housekeeping notes. Just be aware that the speakers are on, the mics are on, so sort of any chatter or anything you say is going to get recorded and put out over the larger Zoom. So please try and remain as quiet as possible. This will be recorded and we'll share that recording sort of next week. So if you want to share it amongst people who weren't able to be here or attend virtually today, you'll have a link in the next sort of week to do that. And then for people on Zoom, we have the question and answer box turned off. So unfortunately, if you're not in the room, you won't be able to ask questions today, but we highly encourage you to watch and engage and enjoy yourself. So, Oscar?
Great. Can I do this, Katie? Just while I'm speaking? Great. So welcome everyone. Very excited to be here and to have an event in person after what it feels like an eternity of doing things on Zoom. We're just talking to Dr. T, which I'll introduce momentarily, that we've been collaborating for a couple of years, and it's great to be in the same room, the same place for once. So welcome everyone. This is an exciting opportunity. This is a new mandate that started a couple of years ago, and we're going to have the opportunity to discuss a report that was recently launched. So Dr. Tlaleng Mofokeng obtained her medical degree from the University of KwaZulu-Natal in Durban and runs a women's health clinic, DISA, in Johannesburg, or Joburg, and she is the United Nations Special Rapporteur on the Right to Health. She's a close colleague, collaborator of the Institute. I'm a little bit starstruck because she's amazing. We have had great rapporteurs, but this is kind of like a breath of fresh air of having someone that is really pushing boundaries and wanted to work adapted for this century. So looking forward to the panel discussion, and I'll turn it over now to Rebecca, or to, sorry, Dr. T, yes, please.
Good morning, everyone. Thank you so much for making this time to spend with me this morning. I am equally humbled and excited and in awe of the amount of solidarity and friendships and scholarship that I have been able to develop with the center over the years. And it really just feels so great to meet everyone in person. It feels like I know most of the people here, but it really is a special moment. And I think in this time of COVID, mental health, we are all just so exhausted, just trying to survive this. And it's these moments such as this that for me are really just so important to replenish, to refocus, and to re-energize. If you can imagine the issues of gender, sex, sexuality, sexual pleasure are not easy subjects to talk about. There's always resistance to that type of discussions. And then compounded to that is the lens that I have decided to take on when I, execute my duties as the mandate holder. And that is one that is influenced by my own lived experience as someone who was a child who had to survive apartheid in South Africa, and how that changed me as a child, and knowing firsthand that I could have had a better childhood and better, perhaps even mental health outcomes as a young person, and how the system, the laws, everything failed me and many others. And so the fact that some of us, get to make it through the system isn't something to celebrate, I don't think. So I then dedicate my life, my activism to ensuring that we create societies, communities, a world where people don't just merely survive, but thrive. And so having studied medicine, I realized how much it's patriarchal, how much is paternalistic, the hierarchy of medical education and the medical system itself, for us as colleagues is leading to poor outcomes for patients, but also our relationships with our patients and the power asymmetry in the consultation room also contributes to that. And so early on, I didn't even know what a special rapporteur was, to be honest. And this is not something that I went seeking. But when the opportunity arose, I thought I could bring a perspective, firstly, as someone who has some experience of prejudice and who still characterizes a lot of the issues that lead to marginalization, to bring that perspective to the role and how I approach the issues of the right to health. Also because of knowing how poor health outcomes affect certain marginalized people, it was important for me to be intentional about defining what those vulnerable situations were and talk more about the vulnerable situations and people in vulnerable situations rather than vulnerable people, because I know that people aren't born vulnerable or there's no genetic disposition to chronic respiratory disease because of racism. It's not a genetic thing. That's things that happen to people that lead to certain health outcomes. And so I drew and leaned on many scholars. And if you've read the reports, you will see very clearly how Professor Kimberly Crenshaw has influenced my view into the world, and using her framework of intersectionality to make sense of the world around me has really helped a lot. And it's about then, I suppose, modifying and expanding that framework to then make sense for the right to health perspective, where we understand that gender, race, class, disability, gender expression, social positioning has direct impact on the ability of individuals being able to realize their right to health. And so mine is to really bring a decolonial effort, and I'm advocating for that to happen because I understand firsthand the impact of, although formal coloniality has ended, but colonialism has ended, but coloniality lives with us because societies are structured in that way. Health systems are still structured in that way. Financing and banking systems are still financed in that way. And for example, when often people will say, and this used to irritate me so much in medical school, you'd hear the professors say, Black women just don't come for their screening for cervical cancer, or when they come, they never come back for the results. And I often stop to think, have they thought about what it takes to leave work, a low-paying job with no labor protections, with a little bit of leave you take for your children when they are sick, right? To then come to a public health facility and sit for 2, 3, 4 hours just to open a file. And maybe that day you will be seen by the doctor and maybe not. So you need to repeat this process again the following day. And how many people have time to continuously go back to a primary health care clinic to queue for admin for 4 hours, and maybe that day they are lucky they get the pap smear. But for them to get the results, it's the same process. It may take 4 or 5 clinic visits, So it's not that people don't know that they should have screening. It's not that Black women are particularly reckless. It's just that the system is designed such that we are always in low-paying jobs with no labor protections, far away from medical centers. So even just getting there, a lot of people, a lot of my abortion patients need to save money for transport for 2 months. By the time they know they are pregnant, they're already 8 weeks. If they have to save money for 2 months, by the time they come back to me, that's 16 weeks, And this is why I'm very also interested in the issues around abortion access in the United States, and recently filed an amicus brief to the United States Supreme Court, again, bringing these issues and the different intersections and why the law in itself can be a tool to further marginalize and oppress people, but also suggest to the court jurisprudence in a way that they can actually affirm the rights of people to self-determine and to really support autonomy. So I see my work as, of course, a human rights defender, but more broadly as a defender of autonomy. And that comes through in many different ways, in affirming transgender health, in abortion health, abortion access, and the rights of adolescents, for example, rights of older women to have sexual pleasure, even in the postmenopausal phase, and of course, speaking about the neglected reproductive cancers. So that's the kind of overall framing, and that's what informs my work. And this particular report was important simply because COVID-19 is an undeniable catastrophic event, right, in our lives. And a lot of analysis has been done on COVID, the impact, what the future may look like because of COVID. But I wanted to shift the spotlight to other important areas that COVID has impacted, that being of sexual and reproductive health rights. And many people, have, questions about the framing of the report, but it really looks at the impact of COVID on the right to health. And the right to health is about access to services, it's about policy and legislation, it's about commodities and services and goods in healthcare, it's about healthcare funding and financing, and of course then the structural issues and the socioeconomic and the underlying determinants of health, which is why in the report I didn't separate sexual and reproductive health from rights. Health care and health provision, even if it's self-managed care, is part of the right to health. It's not a separate entity. And that was deliberate for me and strategic in that I didn't want to give governments and elected leadership and health administrators a loophole where they can report amazing statistics on maternal mortality, on adolescent health and contraception take-up, yet are not providing affirming transgender health, yet sex workers cannot access their occupational tools of trade like condoms. And because often people say, but we are providing good health, and just eliminate and just erase the rights element. And by framing it as sexual and reproductive health rights, you cannot then, as an analysis, report good statistics on health provision without ensuring that the provision of health itself is protecting, respecting, and fulfilling all of the human rights that are related to the right to health. And so those key principles of equality and non-discrimination are important, as well as the principles of autonomy, bodily integrity, and dignity. And I would have succeeded in my role if the people who are often on the margins, who are not heard, not voiceless. People often say you speak for the voiceless. I don't. I bring to the center issues of people who are often not heard. Communities are mobilizing all the time. People are speaking all the time. They are just not heard. And I'm just creating an enabling environment where those voices can come through. And I hope when you read the reports, you can see that intention. And I think sometimes with the pushback I get and from where it comes, I know that I'm doing a decent job at that. And that's, and then that's me. And I think I will allow the program to then, go on, because I want to have a conversation, with you guys. Thank you.
So as I get everything set up on here, I'd like to invite our panelists to come join Dr. T at the table. Cynthia, I may need your help for a second. Max doesn't want to. Doesn't let me go. I touched the screen. Thank you. Yeah, even easier. My name is Rebecca Reingold, for those who don't know me. Can you hear me okay? I'm an associate director at the O'Neill Institute, and I'm really honored to get to please participate in this event as your moderator. I thought that I would start by briefly introducing our distinguished panelists who join our distinguished speaker. So at the far left, my left, we have Matt Kavanaugh, who is currently serving as Special Advisor to the Executive Director for Policy Advocacy and Knowledge at UNAIDS, where he assists UNAIDS Executive Director in creating new policy, advocacy, and knowledge branch that will support and advance the new global AIDS strategy. Following this one-year position, Matt will come back to us at the O'Neill Institute, where he's the Director of the Global Health Policy and Politics Initiative, where he leads projects on global health governance and community-led monitoring, and also played a large role in the creation of the HIV Policy Lab and COVID-19 Law Lab, which we'll hear a bit more about today, I imagine. He's also an assistant professor at the School of Nursing and Health Studies at Georgetown. We also have Viviana Weissman here, who is the president and CEO of Women's Link Worldwide, which she founded in 2001 in response to what she perceived as a glaring need to advance women's rights in litigation in national courts by applying international and regional human rights standards. She has led litigation on numerous emblematic human rights cases before national, regional, and international bodies, leading to historic decisions for the protection and advancement of the rights of women and girls in Latin America, Europe, and East Africa. She has worked extensively as a researcher and has authored various publications on migration, protection for victims of trafficking, armed conflict, and transitional justice, as well as sexual and reproductive rights. She has also organized numerous international conferences and meetings related to those same topics. And finally, connected via Zoom, we have Ian Askew, which I hope I'm pronouncing your name correctly, who is the director of WHO's Department of Sexual and Reproductive Health and Research. In this role, he provides leadership on critical aspects of sexual and reproductive health and rights by shaping and coordinating the global research agenda, setting norms and standards for delivering sexual and reproductive health services, articulating ethical and human rights-based approaches, strengthening research capacity of institutions in low and middle income settings, and guiding efforts to achieve WHO's vision of a world in which all people attain the highest possible standard of health and well-being. Previously, he served as Director for Reproductive Health and Research at Population Council when he lived and worked in several African countries for 25 years. So we clearly have a lot of expertise in the room, and we're really glad to be here in person for those who have been able to join us in person, and thanks to all those who are connected online. So I thought I would start with a question to our panelists and then a question to the Special Rapporteur as well. So to our panelists, I was hoping you could share your preliminary reflections and comments on the Special Rapporteur's report, reflecting on its relevance for your respective lines of work and areas of expertise. And then maybe we'll turn to the Special Rapporteur to give us a little bit of insight about, within a priority setting perspective, what would you say is the #1 measure that states could take to advance sexual and reproductive health rights in the aftermath of the COVID-19 pandemic? So maybe we'll go in the order in which I did intros and start with Matt.
Great, thanks so much, Rebecca, and thanks to everybody for being here, both online and in person. It is an incredible honor to get to sit next to this amazing human being, who is, I think, cutting some incredibly important ground when we think about what rights are related to sexual and reproductive health. So I'm going to talk about kind of 3 things that I pull out of the report that I think are fundamental and central to the ways in which this report moves us forward. So the first is to say that I think Dr. T's focus on sexuality and pleasure in a rights framework is important, and it is a shift, right? We often think about these things in terms of problems. We need responses to sexually transmitted diseases because people having sex is somehow a problem. But if we've learned anything from the AIDS response, we've learned that that is a framework that fails to actually meet people's needs, and it's bad public health. And so what's really interesting here in this report, I think, is the framework of sexuality and pleasure as a key right, because I think that moves us forward in some really important ways. If we think about this kind of respect, protect, fulfill framework, and then we think about sexuality and pleasure in that context, then we see that not only, do we need to respect it, but we need to think about those other pieces. Because if you're going to respect that as a right, then of course you can't criminalize people's sexuality, right? That criminalizing LGBT communities, criminalizing a variety of people, that is not an acceptable response if this is a fundamental right. But then you can jump from that to understand that actually that's a different framing than privacy. Privacy says, sorry, you can't come in, but that's different than saying this is a right, this is a fundamental right that I have to move. And so I think that gives us a liberatory framework and a decolonizing framework that I think is incredibly important. And it leads us to understanding, for example, comprehensive sexuality education, not as a technical matter, not as a must-have if you want to kind of have good public health, but it's okay to not have it if you don't. Instead, if we think about it as a right, then comprehensive sexuality education becomes a right alongside it. Good comprehensive sexuality education that includes LGBT people, for example. If we also think about then what are the tools that are required to protect themselves, we can think about kind of what gives people the ability to have the sex they want. whether that's pre-exposure prophylaxis, whether that's contraceptives that meet their need, whether it's information, these are all key. So to me, that also leads us to a second and third piece, which is that I'll just touch on from the report. One is this kind of intersectional framework that helps us understand the intersection, not of only certain populations have sex, want to have sex, are engaged in sexual and reproductive rights, but instead this understanding that race, class, power, gender, sexuality, these all come together and they influence the ability to realize those rights. And therefore we can have intersectional understandings to overcome those. So in HIV right now, we're dealing with the reality that under COVID-19, we've seen a huge problem in accessing services, but it's not been the HIV treatment services. Everybody's been very focused on this question of, are people staying on HIV treatment on their antiretrovirals? They are. This is good. Our systems have proved relatively resilient to keeping people who were already on treatment. But what they've completely seen decimated is the prevention services, the services that would help realize these rights to sexuality. And those services have been decimated. And there's a conversation around whether or not that's important, right? And it's an urgent matter, so says this report. And I think that that's incredibly right. It also calls out the need to address law and policy barriers to ending HIV by 2030, which is the UN goal. And we just need to recognize that there are a variety of key legal impediments, including criminalization, including the enforcement of laws that really are standing in the way of the end of HIV. And then the final thing I'll say is that we've also got this report, I think, helping us understand in a new way the urgency of getting people access to new technologies as a right? So we are in the middle of COVID-19. We know what it looks like to not choose a rights-based response. What we're seeing right now is the opposite of a rights-based response. We're seeing a market-based response that is failing, that's keeping certain technologies caught up in monopolies in ways that are not liberating that from a decolonial perspective. But it also shows us how this is happening not just on COVID vaccines, not just happening on COVID technologies when it comes to treatment, but also happening on a range of issues. I think right now of the fact that there are HIV treatments and preventative technologies that you can take as an injection that last for 4 to 6 months and are largely only available in the United States of America. And so we are sitting here in Washington, DC, where you can get access to these technologies. And yet, Dr. T points out all of her patients, right, in Johannesburg don't have access to these technologies. And that changes their ability to realize their sexual and reproductive health and rights. So to me, I think this is a powerful report. I think it moves us in an important intellectual move, but it also has some very concrete ways. Sometimes we talk about kind of intersectionality and rights as if they live up in the air. And I think there are these very concrete ways in which today we can see what a rights framework could give us that a public health framework often does not. I'll leave it there.
I agree with everything. I want to start off by saying something. I don't know if this is appropriate. When I read the report, I just wanted to jump up and down. That is a reaction. I read a lot of reports by a lot of special rapporteurs over my 20-some odd years, and having this feeling of just wanting to jump up and down when you read something with joy, that kind of sums up how I feel about this report. But being a little more technical, I want to say you said something in your remarks that to me explains what we at Women's Link do and how what you have produced with this report, like how that allows us to further our mission. You said that growing up, law had failed you and failed others. And what we do at Women's Link and how it is directly related to the report and a lot of the tools that are now in the report for us and for other advocates working on the issue, we look at the law, which is also patriarchal, like health. And we think about how we can use the law, not to maintain the status quo, which is how it's usually used, but to break the status quo. How we can use the law to bring those that are furthest from access to justice, and you speak about furthest of access to health, and we think about it in terms of access to justice, including the access to health. How can we work? So it is, in our case, those women and girls are closer to access to justice, pushing everybody closer to this point. And I think that some of the things that I was thinking about and rereading your report in preparation for this is that from human rights law, from the human rights law perspective, when we talk about the right to life, we talk about the right to a dignified life. And I always go back to where this comes from in our human rights framework. And all rights, like all the rights we talk about, like, you know, at the beginning of the current human rights framework, it all comes from the Universal Declaration. And it's all about dignity. And everything we talk about really is all about dignity. And the inherent dignity of every human person. And what this means in this context, when we speak about sexual and reproductive rights and justice, it cannot be looked at without the framework that you put forth for us of what does it look like from this intersectional framework in which we are examining how everybody can live their life with dignity. And to me, that is what a lot of it, or it all stems from that in my mind. Because defining human dignity is complicated. But attempts to do so allow us to look at diverse manners, which is a lot of what the report does, in which people are stripped of this dignity by those who are ultimately charged with protecting their dignity. And I think that is a lot of what happens and a lot of the framework that you bring back into this issue. And again, this cannot happen without this intersectional gender perspective. And when I think that the work that you do, the work that we all do, you can go into it from all these different angles. We go into it from the issue of women's rights and putting women and girls at the center. And what does that mean? It means that you cannot work on women's rights without working on the cornerstone of women's rights, which is our sexual health, reproductive health and rights, and how those rights are present throughout the lifetime of a person, which includes being free to live, the right to live free of violence, the right to access to sex education. If a person is to become pregnant, what are the rights that the person has, including access to food, prenatal care, access to interrupt their pregnancy, post-abortion care, and all the rights that come that are not related to reproduction, but are part of a person's sexual and reproductive health and rights. And I say person, we include everybody who has the need, including trans women, trans men who might have also these needs. I wanted to take a little bit of time, but I think I'll just mention them to talk a little bit about some of the work that we're doing as a response to what we have seen COVID has brought about to our lives. Inequality and racism and discrimination has always made it so that women and girls are furthest from access. And it's not the same for all women and girls. We all know it's what women and girls don't access abortions, safe abortions, despite whatever the framework is. We work in a lot of restrictive settings. Just yesterday, I was speaking to one of our attorneys, and she says, I came by this information today, and it's just devastating. And it's just one example of so many. She said in El Salvador, a report came out last week that 48 girls become pregnant every day during the last 5 years. 48 girls. And I'm talking about a country with a population of 6.5 million people. And we know this is something that's happening widely across the world. It's increased with COVID because we know there's been an increase in violence and in sexual violence. We know there's been an increase in violence in the homes. And we know there's been a decrease in access to contraception, access to other services. We've been working on a number of cases, and I'm just gonna do kind of a highlight of what they are, and then we can come back to them in case there's questions. We've been working in Kenya on a case with some other partner organizations on how the right to information that is being demanded of the government currently needs to include information about reproductive health and rights, with a huge increase in maternal mortality and morbidity due to women and girls not accessing services during lockdowns because of lack of access, literal access, transportation access to health services. We've been doing some work in Chile around the contraceptive shortage that you mentioned in the report, and how in Chile. In addition to that, and compounded by political turmoil in 2019, there were about 250 blisters of contraceptives sold to women that were defective, leading to unwanted pregnancies in a country where access to interruption of pregnancy is very difficult still, even with the change of the law. We've been working on a case out of Spain to try to lift the block of the Women on website, which is giving information about how women can access medical abortion. The right to information itself being like the portal to even accessing the medicine and the service. And we've been working on the increase of rights violations in Venezuela, and looking at how the complete lack of access to contraceptives there is leading to some coerced sterilization methods due to the needs of coerced by the situation, by the context. So there's just a handful of what we're doing and how to say that the report and the way you're framing the report gives us the tools and the strength to keep going down that path. So we're very appreciative of the work that you've been doing. And thank you for the opportunity to be here.
Thank you, Savannah. All right, Ian, I'll turn things over to you now.
Well, thank you. First, can you hear me okay?
Yes, we can.
Great, okay. Well, thank you very much indeed to O'Neill Institute for the invitation, and many, many thanks to Dr. Mofokeng for the wonderful report that I don't need to repeat the many praises for it, because it really is, for us particularly at WHO, it's a landmark report. It's one that we'll be referring to for many years to come, because it really does lay out so many of the issues that we've been grappling with, and we would grapple with on a daily basis to try to ensure that our mandate in trying to ensure universal access to all sexual and reproductive health services can be filled. And so documents like this, the statements that you made recently at the UN General Assembly, these will really be helpful to us because we are a member state organization. We need to report back to member states on justifying why we're recommending what we do recommend. And so these sorts of statements that draw from real life examples and evidence, as well as legal documents, are so helpful. I wanted to really bring out this issue that of WHO's role as a normative organization, because it has many implications from a rights perspective, because normative guidance has to be defined in terms of the ultimate guiding principle for us, which is the human right to health. And within that, the human right to the highest attainable standard of sexual and reproductive health, specifically for my area of work. And this is an easy thing to say, but it's a difficult thing to implement. And it's something which we're continually moving along with and trying to make sure that whenever we're putting out new guidance around various different approaches to providing health services, that every time we base them in human rights principles. I mean, for example, every time we create a guideline development group to develop new normative guidance, we always include human rights representatives, community representatives in those guideline development groups. In my department, for example, we have a full-time human rights advisor, we have a full-time gender equality advisor, because when we realize that sexual and reproductive health rights are not just technical medical issues or health systems issues. The determinants that we heard about so much about the various forms of intersectional discrimination really mean that we have to look way beyond just the health system and the health system determinants of health. And I was asked to say a little bit about our response during the pandemic, the ongoing pandemic, unfortunately. And I think when I reflect on what we've been doing over the last year and a half or more, we really have had to start from a perspective of what could we say and do as WHO that would enable governments and people to respect and fulfill their right to this high standard attainable for health. I mean, one of the very first things we did was to publicly categorize virtually all sexual and reproductive health services as essential. And I think that message was critically important because coming from the WHO as the normative UN body, it carries a lot of weight with governments. Now, whether they listen to it or not, or act on it, that's another matter. But we were able to put out the statement that virtually all services that you conceptualize as sexual and reproductive health, and certainly all of the ones that were mentioned in the Special Rapporteur's report are ones which we fully align with and support and agree on. And we then also included with that some very practical recommendations about actions that countries could take during the pandemic to try to alleviate the lockdown and other disruptions which were having serious implications for access to services and ability to have the highest quality of care and the highest standard of health. We put a particular attention on issues around self-care interventions, recognizing that for many people they would not be able to access health systems, a particular emphasis on digital health interventions, including telemedicine, and exploring what would that mean, particularly in terms of sexual and reproductive health services. We also try to promote recognition of the minimizing policy regulations around prescription of medications, including for multi-month prescriptions. And we came up with many recommendations for how to provide services outside of the clinical environment. This was not easy because we have to base that on existing evidence, and trying to drum up evidence in a pandemic is not an easy matter. And so fortunately, when we went through our existing recommendations, we were able to draw upon evidence that was based on experiences from many different countries that we could then put out there, and various countries could look to and try to adapt those as best they could. We also picked up very quickly and tried to amplify the messages around the huge increases that we saw in experiences of violence against women and girls, particularly caused by lockdowns, caused by having to stay at home, caused by lack of access to services, and the general change in the economic environment, which meant that many women who had been able to work were amongst the first to lose their jobs during the pandemic, and the increasing economic pressures put on them in having to fulfill their traditional roles in these situations. And so we've tried to make sure that we put out as much evidence as we could to try to encourage governments to respond, NGO sector to respond, and civil society to respond as best we could possible. We've also recognized that there's been a huge infodemic of information and misinformation occurring during the pandemic. And the field of sexual and reproductive health rights has not been exempt from that at all. And so we've spent a lot of time also trying to develop evidence-based questions and answers to respond to the many requests for basic information coming from the general public as well as from health providers. Finally, what we're working on most at the moment is to try to ensure that the lessons learned from guiding and implementing responses during the pandemic can be fully integrated as many countries try to, or at least try to adhere to the rhetoric around building back better and building back fairer. And for that, we really need to make sure that guidance that we provide draws from the rights perspective of we've been hearing about from the panelists, and hopefully in some of the examples that I've given so far. So I'll stop at that point and hand back to yourself and the other panelists. Thank you.
Thank you, Anne. So I'd like to come back to Dr. T. I'll repeat the question because I know it was a little while ago. And also let the audience know that we're going to open it up to questions. So start to think about what you might want to ask the panel. But no, my question for the Special Rapporteur was, with limited resources, what, from a priority setting perspective, there are many wonderful recommendations in the report, but if you had to prioritize one measure for states to take to advance sexual and reproductive health rights in the aftermath of the pandemic, could you pick one and talk a little bit about it?
It's hard. I mean, I put like 10 and that was one. So I think the issue of funding and resourcing is very important. We saw how with the response to the pandemic, which absolutely was necessary, resources, finances, as well as human resources were shifted from primary healthcare and family planning and abortion clinics to COVID-related response. And the risk is that those services will actually be left unsupported. In many budgets, health budgets, you don't quite see the line items, for example, for commodities necessary for safe abortion, medical or MVA. You don't see the line items for the medicines required for these services. And I'm just a bit worried that even the policy changes that have been done in the name of COVID response may remain long after the emergency is over. And many of them relate to restrictions to some of these important rights. And I think you said one, but I think it's linked. For the priority to be set, I think the people who are most affected by the issues are the ones who should be in the room determining, firstly, what are the priorities and what's urgent for them, and how will all of those restore their dignity? Because it's very difficult to, and this is a discrepancy always, right? People who work in global health financing and funding and health aid always ask the question, why are all our efforts and all this money not yielding results? It's not yielding results because you are designing these projects in the global north somewhere, and you come with this template that now must be implemented by healthcare workers in the global south, in the communities, with all of these other pressures that already exist, without actually engaging meaningfully the community to say, yes, globally, we think there's this particular problem, but for the community, what do you actually need? And perhaps it may be infrastructure in terms of roads. And I was in Liberia just at the end of Ebola. And what we saw there, I think, is something that we can learn with COVID, is that the traditional birthing units were actually responsible for much of the obstetric care because Ebola had killed so many nurses and doctors in the Western clinics. And because colonialism and racism puts a hierarchy in knowledge systems, right? The traditional indigenous health systems were always demonized. But with Ebola, they become the backbone of obstetric care. And so without that integration, without understanding what the patient's needs are on the ground, we will always be reacting. And I think for me, the big thing with COVID is we need to rethink completely a new way of being in the world. Because what we had was already unjust and unfair. And I don't know if I want to put energy into bringing that back. I would rather we envision something new. And I think that's one way, I think, post-COVID. But to do that, you need people who are mostly affected by the particular issue at every level of decision-making.
I have a lot of questions to ask the panel, but I wanted to give folks the opportunity who are here in the room to chime in with some questions. Anybody like to take a first step? Please.
Thank you so much to the panel and Dr. T for your report. My question is on the second prong of reproductive rights, that's the right to have children. And I was wondering if there has been any work done or if there are any plans. It's something that had been ignored before COVID, and I think COVID might just worsen that. For many women who want to have children, especially in low and middle income countries, they can't. And they also don't have access to infertility treatments or things like assisted reproductive technologies. And in regions like sub-Saharan Africa, for instance, where the culture places great premium on childbearing and childless women suffer domestic violence, ostracization, and other forms of ill treatment. I think my question is whether you think that any attention they might get any attention anytime soon, or if there are any plans to address infertility anytime soon as part of sexual and reproductive rights.
See if there are any other questions in this round before we move on to the panelists. Any others to add at this point? Okay, then I'll turn it over. Dr. T, do you want to start?
Yeah. So you bring up a very important element, and I think if you look and see, for me, this is why we can't decontextualize the issue, is that a lot of fertility and the obsession that many states and governments have on women's bodies and definitions around womanhood and this essentialism around womanhood is very harmful. And because we know in some areas historically, reproduction was encouraged when governments thought they needed economic development, right? And they were predicting their upward curve in GDP, and they needed people to be in the labor market. So there are governments who used to pay women to actually have children. Yet in the developing context in the global South, when women are given social support and grants, you'll hear things like, oh, these young women are just having children for a grant. So the narrative is very different depending on who is being spoken of. And so I think and I must remind you, by the way, that the right to benefit from technological and biomedical advancement is a human right. It's already recognized. So it is something that we should all be advocating for, but it speaks again to the resourcing of primary healthcare facilities where people reside. And it's part of the bigger conversation about peri-urban centers, rural areas, and the developmental agenda. And those neglected issues are quite important. And it has come through when Matt was speaking, I was thinking about it, how often we used to advocate for women who are HIV positive, right? To protect their right to actually have children. And that's when the issues about, let's not worry too much about the CD4 count, and let's rather look at the viral load. And if that's undetectable, we know that the pregnancy outcome for the pregnant woman and the fetus will be better, right? It's all because of that push to say, regardless of your health status, regardless of any status, disability is one of them. A lot of women who are dealing with disability and reproductive health problems are still not also considered, properly in the medical fertility. So yes, I agree with you, and I think that's a brilliant issue point to advocate for. But again, it leads to issues of research and development within countries. The departments of science and technology, for example, how many feminists and women are in those departments to then do, and I mean, if you think of abortion care, the tools we use, the medicines we use, there hasn't really been that forward, breakthroughs in terms of technology. We are still stuck where we're stuck. If you think about the female condom, the internal condom, we now call it the internal condom, it's still that very design that none of us enjoy. It's hard. It makes squeaky noises. It's just, so all of that is related, right? It's all within that spectrum. It can be as simple as talking about the internal condom and lack of development there, and how the world just doesn't prioritize, and the medical world doesn't prioritize sexual health and sexual pleasure of women, right? And so things like assisted fertility and those technologies for rural women, indigenous communities, when we demand them, the system looks at it as if we are asking for extra things, but they're not extra things. These are really about rights. And one way of advocacy that worked really well is for women who have HIV. So now we have things like sperm washing and rinsing and all of that. It was precisely because of, it was inspired by those kinds of questions that you raise. Yeah.
Would any of our other panelists like to speak to the issue of infertility and treatment?
Can I say something?
Please, yeah.
Thank you so much for that point, because it's so rare to hear that question when we're in a discussion on sexual and reproductive health and rights. There's a lot more attention paid to other areas, and it's such a difficult area to address for many reasons. And I think, as I think you said, the first one is stigmatization. It's hugely stigmatizing to be infertile or subfertile anywhere in the world, but particularly in societies where high fertility is the norm and there's an expectation for both women and for men to be fertile. Secondly, the treatments that are currently available for fertility care are hugely expensive, way beyond the reach of many people, not only in low-income countries, but high-income settings as well. And the investments going into trying to develop lower-cost fertility care is still a long way to go. I mean, here at WHO, we're very actively involved in trying to promote the development of low-cost fertility care, fertility treatments, to try to get better understanding of the situation in different countries. But it's a difficult area to raise investment and interest in. I mean, for example, when we use the expression family planning, everyone automatically thinks of contraception and perhaps abortion. No one thinks about infertility treatment as part of family planning. And this is something which we've been trying to promote a much greater consideration of the breadth of fertility issues faced by people, because it's, we even have such poor estimates, we don't really know what proportion of the population is affected by infertility. It's at least 10%, if not more. It varies greatly depending on other situations around the world. But it's an area where rights still are being grossly non-respected, disrespected, whatever you want to say. It's such an area of gaping implementation that we really don't know what's going on. As you maybe know, in recent years, there's been a lot of issues around rights associated with surrogacy and so on, and that, particularly in the US, has been a major issue. So really, I mean, sorry, I could go on for a while about this. It's a particular area of concern for me. So thank you for raising it. But yeah, I think it's an area, and just relating on the pandemic, right at the very beginning of the pandemic, we received many requests for guidance from fertility care specialists saying, given what we don't know about the transmission, etc., should we continue with fertility treatments? And in many countries, they were put on hold for 6-12 months until the evidence came through that the fertility treatments should continue. There is no risk from the infection. So anyway, that's probably more than you needed to hear, but thanks for raising that issue.
I just wanted to say one quick thing. And I think both the question and the answers just were making me think, and it's so true, this idea that there's so much stigma around the issue of infertility. And it's so interesting, there's so much stigma around abortion. And there's so much stigma around sexual violence for women. So it's like, there's just so much stigma around these issues. And I think that for me goes back to the importance of the framing of the way that this report is framed and this conversation is framed about what needs to be talked about from a health and human rights and human dignity framework. Because if not, we just live in not talking about it because of the stigma. And I think that's just kind of called my attention from the answers. Thank you.
Just quickly, I think it's really important to pay attention, and I'll just to part of what this new report is doing, right? It's making the jump to talk about this as a rights framework and as an individual rights framework. And if that is the case, then individuals have a right to fertility and sexuality. And the question is not first, does your relationship result in the kid, right? The question is, what do you need to meet your needs? So sometimes the issue is biological challenges. Sometimes the issue is that two men have a hard time having sex with each other and producing babies, right? The majority of children in much of the world do not grow up in their entire lives in a two-parent heterosexual household, right? Their entire lives. And so what would it look like to think about this from a rights perspective that says everyone has a right to realize their aspirations around fertility, around family, and to bring that into perspective because we are in a world where the technology exists. And this is where I think it deeply comes back to the point you were making earlier about the right to access the best scientific technology that's the core right. And it's not that we don't have the technology, it's not that hard to actually address these issues. The question is who can have access to it and how and why and what do we understand to be core human rights issues, but also core health services, and how do we define them going forward? So I think it's important.
Great. So we have a couple questions from the folks who are connected by Zoom. And I'm gonna read one because I think it touches on some issues that various panelists can address, even though it's directed at you, Dr. T. It's many African countries inherited colonial laws that criminalize abortion. For example, the criminal codes for Tanzania and Malawi that criminalize abortion. How then can human rights advocate for a push to colonialize these criminal laws?
Yeah, and it's also about adolescent health that's criminalized. It's about same-sex relations that are penalized. And it's a very weird situation with the African context because there's a resolution 275 of the Africa Union that actually speaks about preventing and ending violence based on real or imputed sexual orientation or gender identity. So we have this amazing document as a resolution that was adopted, and yet it never comes to life in terms of the region and what then happens domestically. And that's part of the challenge that I have is how do we operationalize the right to health? And I think the only way we can do that is to look at the law and policy as living documents. They are not done once off and that's it. When evidence and contexts change, we need to be able to access legislators and lawmakers to present the evidence and the context and actually then get the laws to meet the needs of those people that time. And the human rights application, of course, of respecting, fulfilling and protecting rights, I think ultimately talk about affirming people's humanity. Because what colonialism did, and of course in policy and legislation it's very clear, but it also dehumanizes us, You can be in a shopping mall and someone bumps you because they expect you to move out of the way. And then they say, oh, I didn't see you, right? So there's a microaggression and a racism that also plays out in real life that often manifests itself in many other ways. And so the law has to constantly be reviewed. And legislation has to be constantly updated. And if you look at many countries around the world, and this is true also for my own country, we have acts and laws that we are still referencing from the apartheid era, which tells you that when democracy happened, there wasn't enough attention paid to how racism was legislated in South Africa. And so when today we live in a democratic country and a large population still don't feel free, the ultimate goal is for freedom. We all want freedom. So if we still don't feel free, even in a democratic country, it tells you something about the way the law is applied, the policing methods are applied, by the way, and it trickles down and up to the way that the healthcare itself is delivered. And that's why my next report looking on gender-based violence is not going to look only at interpersonal violence. It's going to look at how the law itself, it can be violent, how states can perpetuate and enable violence, but also look at architecture and infrastructure and social spaces and how they themselves enable violence. And we can understand it from a disability point of view in terms of accessing buildings, right? But think about it as a gay person or a lesbian person or a non-gender conforming person who needs to use a restroom. So all of those laws, and it's such I'm trying to find a dignified word and a diplomatic word for it, but it's a very unintelligent thing to carry on to these and carry on implementing these colonial influenced policies. But it actually speaks to the fact that people are not in this work for all of our freedom. They just want to be the new master. So patriarchy is like a boys' club, right? It's about who can be at the top. It's not about dismantling the system. I just want to be the leader of the system and you all can remain where you are. And that's why they don't see the need for it to change. because it still maintains power. It still gives them power to make decisions over what happens on the ground. And I don't think that, Adriana might shout at me, but I don't think sovereignty is an excuse to violate human rights nationally and then say, well, we're a sovereign nation. I think we need better mechanisms of accountability, and that also feeds a little bit into that. I think it's the most unintelligent thing ever to be holding on to these laws and policies, but because they enable patriarchal power and violence that I speak about in the report, many will maintain it because it gives them power and enables them to get away with many things.
Other thoughts? Yeah.
Yeah, I think that the whole idea of, I think, Dr. T, when you were speaking, you talked about like health systems being within the colonial mindset. And I think that this question about the laws is also, there's direct, I mean, there are countries, Anglophone African countries that were colonized by the UK, many of them, their criminal codes are from, they mirror a 1963 law in the UK that prohibited abortion. And those laws are still in the books in many countries. And then, after the end of formal colonization, there was a move in the interpretation of those laws in the UK and other Commonwealth countries. And now there's a very strong women's rights and sexual and reproductive health movement in these countries and talking about like, what are we doing with these laws on the books and what is the change that's necessary? And these laws are actually inherited from the colonial period. And then there's this very strong kind of anti-rights opposition groups that are coming in, mostly funded out of the United States, that are saying that the push for access to reproductive rights and abortion is a Western notion with no discussion about the fact that the laws themselves are colonial laws in nature. So there's a lot of contradiction in the way that these conversations are happening. And I think that that's a part of it, which is the formal law aspect of it, which is completely colonial in nature directly in this case. But then there's this issue that you're speaking about is this structural discrimination that exists in the legal, not just in the laws, but the application of the laws. I always think about how what happens when a woman goes to denounce sexual violence, like what are the stereotypes that are applied, and how women is often treated when she's denouncing sexual violence. The law might be great on the book in terms of like what the sexual violence laws are, but is she being questioned, or is she, which is usually what happens. And I always think about this in terms of sexual violence, because I think, if your car gets stolen and you go to report that your car gets stolen, it's highly unlikely that they're going to ask you if you're sure that your car got stolen. But why is it when a woman or girl goes to say that that's been sexual violence, that there's so much questioning of the fact whether this crime actually took place or not? And so it's to me, that's the whole system with this patriarchal notion of women as people who should not be believed per se. And then you add that to that, like, is it a poor woman? Is it a young woman? Is it a woman who comes from a rural setting? And like, what are the possibilities of women being believed by the legal system, all of it that is meant to actually protect her? So it's all like these levels of discrimination that happen, even once you can get a good formal law in place. So, yeah.
Any other thoughts from the panelists? Any other questions here? So maybe we'll do you and then you, and then we'll hear back from the panel.
Hi, thank you for coming. This has been extremely informative and exciting. I had a question that is not technical, so I wasn't sure if I wanted to ask it, but based on those answers, I want to go there, I guess. So we've talked about how we have these systems that are based on sexism, racism, these societies that have been built this way. And every time we have certain advances, we get a lot of pushback, right? And so I guess I wanted to ask you, and then I guess the panelists from their outside perspective, in the year plus that you've been in this position, you broke a lot of glass ceilings, but by coming into this position, I feel like, and so what have you sensed has been whether you've, how much pushback or extra pushback have you gotten because this is coming from you? And how has it shifted, if at all, the perception, because these issues are not new and we've been banging the drums for a very long time, but now you are in this position, you have this expertise and you are the one banging the drum. So how have you perceived the reaction? And then again, for the panelists who've been in this area, have you noticed anything from the outside?
We'll take one more question as well.
Hi, sorry. Thank you so much for being here today, and thank you, Dr. T, for your report. I was particularly interested in your section on reproductive cancers, and particularly I'm quite interested in cervical cancer and how we can eliminate it, because the fact is it is a reality that we can eliminate it. And we know it's the 4th most common cancer in the world, and it only affects women, and over 300,000 women die of it annually, and 90% of the deaths happen in low and middle income countries. But how can we draw more attention to it and get the funding that we need to actually eliminate it? Because it does only affect women, so it seems like a lot of the world doesn't really care about it as much as other cancers or other diseases. So yeah, what are your thoughts on that? Thank you.
Can I go for it?
Yeah, so I'm not sure about the glass ceiling thing, because sometimes I feel like I'm in a little tight bottle and I just wanna, and I think for me there's a difference between diplomacy and just being too overly respectable. And sometimes when we do this work, I find that we get too worried about how we come across, how we sound, so I believe profanity where it's necessary. You won't see it in the report, but if you know me and you read the report, you will know what Dr. T really wanted to say, but this is what she said instead. And I think because a lot of how we are raised also as girls, but also as people whose parents had the trauma of living in racialized and apartheid situations, right? Is that they were scared for our survival, right? So part of how they raised us was to just play within the lines, and you'll be safe and you will just maybe make it. And then one day you may just be able, and it's not their fault. They were living in a world where survival was key. And that's why my focus is now we just don't need people to survive. We need to thrive, and we can't get there if we are going to write letters and ask nicely for our power back. You take it back. You don't ask for it nicely because it's not taken from you nicely. I think what's also interesting for me is that with the announcement of my appointment came very excited people, but also very unexcited people, and they made that very clear and very known, and most of it coming from the US, published blogs and all sorts of things, calling on the UN not to appoint an abortion provider, and she's a sex work decrim advocate, and polluting the crystal UN and the perfection of the system. So that's how I came in. People who are opposed to these rights, that's how they frame me and that's how they view me, and it's fine. And I think the day they write wonderful things about me, I'll be very worried. So it will be a check-up on me if that ever happens. And of course it's increasing, whenever you then, because like you are right, we've been talking about these issues for a long time. But the minute you come from it, when you actually naming patriarchal aggression and violence, if you are naming imperialism and this obsession with world dominance by particular nations, right, and how they use foreign policy to do that, you're not going to have lots of friends, and which is fine. I think as a Black woman, and then you look at the age, there is that element of, but this young one, right? So that ageism is also there. So I call myself an elder youth because I'm not so young, but I'm also like not in the other groups. I'm like somewhere in the middle where I'm like in a lost sea, so I'm an elder youth. And if you look at the WHO, UNFPA, UNAIDS definitions of, categories, I I really am in the lost sea. So, but am I right?
Yes,
I am
yes,
right.
yes,
So I just made a new category and I said I'm an elder youth. So as an elder youth, it helps me though to take particular risks because I am a medical doctor. And that degree offers me a particular protection that many other Black women do not have. They've been saying what I've been saying for years. And that's why for me, this work is also part of resistance from erasure of scholarship of Black women who have gotten us this far. And just the other day, I was doing a keynote on environment and health, and I was talking about Wangari Maathai, right? About her work as a feminist who was an environmentalist, that these frameworks and these answers we are looking for about climate crisis were already being said. They are already there. But because it's Black women who are poor from the global South, they are not the experts. But if a white person comes to Africa for 2 months, spends a month in the Serengeti, 1 month in the clinic, they come back and finish their PhD, they become the expert in global South, right? So we need to change just even how we think and relate to productions of knowledge and who is seen as an expert. And so because I'm a medical doctor, it becomes very difficult for people to just tear down everything. They try, they'll come for your character, they'll come for everything, but truly they know they can't come for the content because you've got the receipts. And so that's just what it is. But it's there and they make it known, very much. And social media, of course, enables them to spew that stuff directly at you. So you kind of have to manage yourself and your own exposure. The cervical cancer question is important. And I actually included it there, partly influenced by the WHO and their declaration to want to eradicate cervical cancer. And I'm also quite intentional with amplifying and coordinating and working with other UN agencies like UNFPA, WHO, and UNAIDS, particularly. A little bit of, UNICEF will still figure out the entry point there. But it is about having the human papilloma vaccine to boys and girls everywhere, not just girls, right? Because we know scientifically it's actually penises that transmit the HPV, but it causes cancer in the cervix, in the uterus. And we also then need to de-gender health and medicine because a lot of people who are children who may be gender non-conforming. So if you say, well, we're giving HPV vaccines to girls and you have someone who's gender non-conforming but actually has a uterus, then they're already cut out from life-saving treatment at that early age. And that's why we have to let go of these very binary and very cis heteronormative ways of thinking about our bodies and the world. And it affects how we program, that affects how we offer screening to people. And so screening, of course, early screening, early detection is still important because we know that even in the timeline of the WHO, it's very far ahead. We won't get to the eradication soon enough. So we still need the screening to happen. We need the technology to be available. Something is called colposcopy, low, what is it called? It doesn't need too many people to make it work in rural settings, right? Where we know power cuts are a thing. So if you're gonna have these huge laboratories that need all of this energy and power, and you live in Johannesburg and every other day there's power cuts, that also impacts our ability to provide care. So we can't plan and do healthcare resourcing and management without talking to our colleagues in infrastructure, without talking to our colleagues in energy and all of that. That's why all of these issues are important and that's where they intersect. So when there's a climate crisis, it directly affects the ability of migrant population and indigenous population and small developing islands. If they have to leave their homes and they come to the United States and they get sent back home, then what about the right to health? You see what I'm saying? And then it's the same with Europe. When a lot of migrant Black people are going into Europe and then they get there, they are undocumented. And every time you need services, the first thing people ask you, give me your ID, proof of your documentation. And when people don't have that, what does it mean if migration status is what blocks us from accessing care? And then that's true for the vaccine for COVID, how, we've been fighting that everyone everywhere who needs it must get it without any, hindrances. But I think that cervical cancer one is a direct inspiration from the WHO program.
So can I just come at this from a slightly different perspective to say as follows? The thing that you said earlier that I think was just incredibly important and that I want to make sure we don't gloss over is that this question of who gets to participate in the decisions when it comes to both domestic and global health. I think we are in a moment where we are actually in a very dangerous turning point, where many amazing thought leaders are moving this one agenda, including Dr. T, that are moving the agenda of decolonizing global health and thinking deeply about what that looks like and making critical, important moves in that direction. And at the same time, COVID-19 is showing us that we are not making progress, and in fact, we are losing ground on that. That in HIV, we have from long experience discovered the very clear result of what happens when you do not consult communities affected, when you do not consult political leaders of communities affected, where you do not structure your funding and your interventions based on those who are affected by the disease. And then under COVID-19, we seem to be reverting from that. I'll just say that from a perspective, I've been shocked to see that the Global Fund to Fight AIDS, Tuberculosis, and Malaria, that as a funding mechanism, I have huge criticisms of exactly how that works, but I thought it would be the floor of how we thought about participation, about who gets to make decisions, about who's at the table. And then under COVID-19, I've been shocked to see that we haven't consulted the president of South Africa, the African Union. When you've got leaders, scientific leaders, business leaders, et cetera, from the continent saying, knock, 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 you're designing an entire structure meant to benefit us, and you haven't actually listened to what we've said, which is that we don't want the structure that you've created. We propose something else. And so that's where we are, we're not moving in the right direction. And so I do think that one of these moments of crisis, out of this moment of crisis, can it be born something that takes what you're describing and does really think about what are the structures of power, what are the decision-making structures? Because sometimes we say, these are something we'll worry about later, we can't do it in the middle of an emergency. Well, what we're doing right now is we're designing systems that are not working because of the way that we've created them. So how do we shift the politics there? How do we create governance structures that are able to do some of what you're talking about here, not on a micro level only, but at a micro level and at a macro level? And I think that's the question that's being called. And I think there's a lot of legitimacy that's being lost within global health right now, where many world leaders from low and middle income countries are turning away and saying, sorry, these structures are not working for us, and therefore we're not going to participate. And I think that's going to create a crisis and forward a crisis that's probably going to be powerful, important, and hopefully transformative as we go.
So I think we have time for probably one more round of questions, and I have some from Zoom that I'm going to attempt to group a little bit, because I think there's some interest in the issue of telemedicine and other technologies and the role they can play in increasing access to sexual and reproductive health services, but also maybe some of the challenges that come up when there isn't access to digital technology in a given part of the world. And then there's another question about the role of cities in protecting sexual and reproductive rights during the pandemic. Since we know that systemic discrimination is often embedded in the way that cities are designed and governed. And so this person is interested in understanding if there were any actions promoted at the city level during the pandemic to specifically address the rights of vulnerable individuals or communities, any case studies, best practices that we could look to as a best practice. So I will turn things back over to you all and see if anyone wants to.
Yeah. So digital technology for me, I think is the most powerful tool currently that we can use. And of course, a lot of young people in particularly sexual and reproductive health rights area have been doing amazing work for many years before, up to a point now where we actually recognize what digital innovation and interventions look like in public health. Many of us started talking about sex and orgasms and pleasure and all of those things on Twitter a decade ago now already. And even then, we were still like, as medical providers, should we be using social media? What does this mean for, up until now, where it's an actual, defined, clearly impactful and measurable, way of outreach. So digital technology is very important. What we do need to be careful of, though, is that the artificial intelligence isn't neutral in these apps. The people who are coding the apps, if they are sexist, racist, ableist, transphobic, that's what the app is going to feel like. So the app will have the dangers of replicating the inequalities that are already existing unless we use a rights perspective and a framework. And so there's a lot of amazing work that's coming through, and one of the reports, mine, will be on digital health and innovation and the right to health, and providing some guidance and recommendations on how we build, how we implement, how we measure. Issues of privacy and confidentiality are important, especially as principles of the right to health. So when governments can then know how many people are using the app and for what, can they track? What are the laws governing personal information? Where is the data being stored? Who is in charge and who owns the cloud? Those are very important questions as we think about this very new area of development. And I say new because it hasn't been, I don't think, commercialized, and capitalism hasn't really, clung on it. And once capitalism does that, we risk, before we've defined it for ourselves, we risk it being just another capitalistic, venture. And I don't think that will serve us any good. The other issues about, enforcement of, the cities, right? And how that is important. And what we saw in many countries is that the enforcement of lockdown was being militarized, and police were also being used, right, to enforce these laws. So you had young people, women, queer people having to out themselves and say, well, I have to go to the clinic for PrEP, or I have to go to the clinic because I want an abortion, or I want a pregnancy test. I'm not even sure if I'm pregnant. And we know that, the disruptions in contraception. So it needed a lot of people to almost, there was just too much of a fertile ground for rights abuses to happen, where healthcare was no longer in the hands of people who have medical ethics guiding them, such as doctors and nurses. We took a step back, even with health communication with COVID. It was the politicians all over the news every day, not the health workers, not the scientists, we were there to comment on what the politicians were saying, but we were not leading in the communication. And so even with the enforcement of social distancing and those lockdown measures, I saw a clear negative impact of how that was done. And people were risking criminal records if you got arrested, breaking a curfew. You risk a prison sentence. Some people were shot in their backyards, literally killed. A child who was autistic, who obviously was not responding verbally to the police, was shot because he was suspected of not taking on the orders of the police. So there has been real documented violations of how the police and the military was used in a response of a health emergency. And that's one of the ways that I think we have failed catastrophically in terms of human rights principles in this pandemic.
I just wanted to quickly add to the comments about the technology, just the very important aspect of the right to information and how that can be used both proactively as a method of accountability against states when the right to information about access to the health services aren't being provided, but also when there's misinformation or disinformation and what the obligations are of states in that. And I think that there is a fertile area of law and using that as a tool in order to accompany some of the work around technology that I think is worth thinking about.
So two brief things. One to say, so in HIV, what we've seen is actually a very mixed record when it comes to telemedicine, right? That on the one hand, you've seen this kind of in some settings really advance people's access and it's been in important ways. But we now have very clear empirical evidence that telemedicine has resulted in the fall off of many of the most marginalized people from treatment, from prevention services, from sexual and reproductive health services. It's no longer a question like, was this a problem? The answer is it has been a problem, right? And so we need to grapple with that and limit, I think, the degree to which we see this as any sort of solution. And in fact, it can be a solution to parts of what we need, right? It could be an important solution for certain people, but it is a solution that potentially exacerbates inequalities rather than reducing them. And that is something that we have to tackle very, very clearly. The other thing I'll say is that, so Rebecca, you mentioned at the beginning kind of the HIV Policy Lab. through the HIV Policy Lab and also our COVID Law Lab here at Georgetown, we've been tracking laws around the world. And one of the things that we see is that most legal infrastructures are nowhere near prepared for the technologies that you're talking about, Dr. G, right? That as we think about the kind of protections that would be needed to regulate and be able to ensure that health information is kept private, that the legal infrastructure is not there. And the World Health Organization, we have WHO with us, it has done a great job of actually outlining what would good legislative and regulatory capacities around this look like. And the reality is that if you actually look at the legal infrastructure, it's nowhere near catching up to what WHO has described. And so this, to me, I think is an incredible piece to tackle, and that the technology is moving far faster than the legal response to it. And that is putting the most marginalized at risk. You know, I think a lot about kind of, you know, the key populations that we work with in HIV, for example, sex workers, who under COVID-19 have been told move to telemedicine, which means that for the first time, many of them are having to write down the fact that they are sex workers in order to get access to technologies that otherwise would just be something they would go to a clinic, they would be seen by any number of people, and quality providers would never write down where the police would see that they were sex workers. But it's now going into people's records, which means they're making one of two choices: either not to go, or two, to subject themselves to risk that they didn't otherwise have. And so those are the kinds of things that we have to tackle as we go forward.
Ian, did you want to add anything, or are you set?
No, just to, support everything that's been said. And I think, as you've heard, we at WHO, we put out some guiding principles a few months ago. And it's interesting that, they're all about protection, because at the moment we need to be so cautious about moving forward with artificial intelligence specifically, and with digital health interventions more generally. But we've created, the last couple of years, a whole department specifically dedicated to looking at digital health and the legal, ethical, and moral implications of moving down that way, for all the reasons that we've just heard. Because it is going to be the way that health is provided going forwards, and we have to find the best possible ways to make sure that everyone's rights are respected. And at the same time, healthcare is improved and health status is improved.
I'm going to invite Katie back up to give some closing remarks, because I think we're just about at time.
I hope everyone has enjoyed this unbelievable conversation. I want to say thank you so much to our panelists. So we can give all of them a round of applause. Thank you so much for coming. For anyone that's here or listening via live stream and close to the Georgetown campus, we're going to move over to the library green, where hopefully you can get a chance to meet Dr. G. We'll be outdoors, we'll be a little safer, and ask any other questions you have. But a huge thanks for being here. We're incredibly honored, and look forward to all the work you're going to do and some of the work we can help support. So, of course. All right.